Great to be here with you. Thank you very much for the opportunity to be here. The last session was really a wonderful lead-in. Heard the word analytics, heard some of the challenges in care and quality and cost and value. And you know, if you live in Nashville and part of this vibrant healthcare community that really extends through the country and worldwide, you can't help but think of how innovation will shape the future. That's really what I want to talk about, is how data and analytics and cloud and mobility, things that we think are very much a part of the future, will disrupt and really provide a dividend for something that's already here. So I want to first begin by saying thank you. Thank you for the opportunity for being here. Thank you to Jumpstart Foundry. Thank you to my team and home team at Perlin, all of you who are entrepreneurs. But you know what, ladies and gentlemen, this is more personal. I want to thank you big time. I want to thank you for $30 billion that you invested in health information. And I want to thank you even more because that investment we made with 323 million of our fellow citizens, and that means that you personally and I ponied up about $100 a person. So I really want to say thank you personally. And you may be wondering with that, what are you going to get? What's your return on the investment that you've already made? And by the way, with that great investment, what can your country do for you, and how can you as innovators, entrepreneurs, really help to shape that future, address the challenges that Larry and Dick and Jim so eloquently described just a moment ago? So yes, interoperable health information is about moving information to follow patients so patients can get the care as they move around and help to coordinate care among members of the team. But there's also the opportunity to be a learning health system. It's not a new concept. Actually, in 2007, the Institute of Medicine, now the National Academies of Medicine, said that a learning healthcare system is one that's designed to generate and apply the best evidence to drive the processes of discovery as a natural outgrowth of patient care. If you think about it, a learning health system is one then that commits to using the data that are inevitably generated as a natural byproduct of care to shape the care of the future. And it can actually be continuously improving if it actually uses those data through analytics to put the better care into practice. So what's occurred over the last few years? I've been watching this pretty closely, had the opportunity to chair the Health IT Standards Committee for Meaningful Use for 5 years. And to me, one of the most important things was not only that records could follow patients, but standards allowed handholds so that innovators and entrepreneurs could develop new products, new apps to ride on top of legacy systems, et cetera, and extract data to really create knowledge to shape a better, higher quality, more compelling healthcare of the future, which may, as was just said, be delivered not only in the traditional mainstream organizations, which will always be necessary, but complemented by others. So if you look at the country, this is the most recent map that ONC has published, and this shows that high-tech, meaningful use really led to a lot of very rapid implementation of electronic health records in the hospital environment. In fact, one of the things that was gratifying was to see that there were very little in the way of disparities between big hospitals, urban hospitals, and small and rural and critical access hospitals. And in fact, these numbers are even higher now. It's in excess of 95% of American hospitals. Ditto for physician practices. You can see the differences between pre-high-tech and post-high-tech. And this is even further, but not quite as penetrated as the implementation of health records in hospitals. What does that mean? That means that if you think about it, over half of hospitals now, over half of physician practices and over 95% of hospitals are clicking away, using those systems, creating data. And that's good. But I'm really excited about the next step, which is translating those clicks and data into applicable knowledge. What if we could tap into the collective memory of healthcare to understand variation, understand what works better, what works worse, and really use that, ideally in real time, to improve care and for discovery. Imagine better care, better health, better policy, as we heard from Jim Cooper this morning. Well, more recently, the director of the Agency for Healthcare Research and Quality, Richard Cronick, asked, when do we get to a system in which learning healthcare supports continuous quality improvement? Well, I don't think that vision is far off. One of the advantages of having a large platform, a health system, is that we can ask these sorts of questions and answer them by ways that were made possible by the implementation of electronic health records. So I want to share two case studies really quickly. One, the reduced MRSA study, which was a novel approach to reducing not only MRSA, but preventing bloodstream infections. And second, a way to improve outcomes for new babies and moms. And then wrap it up talking about the big data dividend. Well, big problem. About 1 in 20 patients who leave the hospital, if they're fortunate to leave the hospital across America, leave with something they didn't come in with, a healthcare acquired infection. It's about 2 million individuals a year. Some of those individuals pay the ultimate price, 80,000 a year, die because of healthcare or hospital acquired infections. It's also a financial cost. It's about $20 billion. And forms of staph, including methicillin-resistant Staph aureus, or MRSA, contribute to about a quarter of the infections and deaths. Imagine if you could improve that. Well, in HCA, we wanted to set out to reduce our infection rates and be a lead in the world. And in fact, we couldn't find much in the literature, so we looked worldwide, looked to the Netherlands, looked to the Scandinavian countries, where they had lower rates, and were able, by screening patients for MRSA and isolating them away from other patients, to reduce our bloodstream infection rate to a third lower than expected. This is called an observed to expected infection ratio. And so 0.7 is good. There are a third fewer infections than would have been expected for those patients. So I actually had the opportunity to present that at the Institute of Medicine, where it had gotten some acclaim. We had published on this, and I was feeling pretty good about that. But after the Institute of Medicine, no good story starts any other way. So there we were, sitting in a bar, and admittedly next to the Institute of Medicine. A couple of the colleagues were asking, well, you know, John, that's good, but how do you know it's best? And really, among competing practices, can you define what might be the real best? And they said, could you use the information that's been liberated by virtue of high-tech and meaningful use, and HCA as a platform with multiple hospitals, to ask a question that compares 3 practices? So the research is called pragmatic research. It was done in real-world environments by real-world practitioners without changing everything around. It was comparative effectiveness, 3 different approaches, and here were the approaches. 1, screen the patient, and if they're positive for MRSA, isolate them, what we were doing, base case. 2, screen, isolate, and if positive, an antiseptic sponge bath, chlorhexidine, and nasal antibiotics, mupirocin, for 5 days. Or novel approach, type 3. Go in, and if the patient, give the patient the sponge bath and the nose drops on the admission to the intensive care unit. So here's what we did. We had baseline information by virtue of high tech, and we were able to collect that data, and we divided 43 hospitals into roughly 3 equal groups. In total, catch this was 75,000 patients, 74 ICUs, 280,000 patient days, and we did this experiment, and here's what happened. Well, actually, here's where the experiment was. The baseline data were collected across the country. We're predominantly a Southern organization, Southern company. Screen and isolate, isolate and decolonize everybody. Okay, what was the answer? Well, this is called a frailty hazards model, and it says which is better than the other, but importantly, it says what's best. And best by a long shot was Arm 3, the novel approach. So what we were doing was good, but it turned out not to be the best. And important fact is that this translated into, on top of every best practice Don Berwick bundle that was known, on top of what we're already doing, it reduced bloodstream infections by 44% in the experiment. In fact, for every 99 patients who were decolonized by that strategy, you avoided 1 potentially life-threatening bloodstream infection. So published in the New England Journal are terrific collaborators here in government, Agency for Healthcare Research and Quality, CDC, Harvard, Hospital Corporation, et cetera. And this was really notable not only for cutting bloodstream infections by nearly half, not just MRSA, 37%, but all infections by 44%. But think about it. What if it were done in 1 hospital? If you do the math, it would have taken 1 hospital 64 years. Instead, it was 43 hospitals, 18 months. Implementation by usual healthcare workers, setting, not in a controlled research environment, but in the real world. So here's a take-home. Because of interoperable health information, reduced MRSA efficiently answered real-world questions in real-world environments, which scientifically we believe has every reason to generalize to other real-world environments and now is a recommended best practice. Okay, let's talk about the scale and speed of learning. This is the ALLHAT study. It was formerly the largest study ever done. It was 33,000 patients actually comparing two different strategies of antihypertensives, calcium channel blockers and ACE inhibitors. Long story short, 1990 is when it was funded, 1992 is when it kicked off. It took 10 years, and it was 33,000 patients versus 75,000. It was $80 million in 1990 dollars. I just calculated that this morning. That's actually $146 million in 2015 dollars. And by the way, as I said, 10 years, not 18 months. So why was this possible? The terrific collaborations that I mentioned, our organization was committed to this. We made financial investment. This is efficient, but it's not free. We were able to use randomization by hospital, but ultimately, it was really by virtue of having interoperable, interconnected health information. Let's dive deeper into that. Standard information platform, more or less, but then by virtue of the standards, we were able to make sure that sodium in California equaled Na plus in Kansas, equaled Na in Tennessee, so that something that meant sodium meant the same thing across the country. We're able to pull the data together into one repository. We think about these terabyte data systems today without batting an eye, but this is something that's very different also than ALLHAT. Normalization of data, continuous quality improvement on the data, and the ability to analyze the data at rest as opposed to transporting it provided exceptional security. Oh yeah. And here's the other thing. What happened when, as they say at Microsoft, we ate our own dog food? On top of the good practice that was already occurring, we didn't get the 44% that the study predicted, but when we put this in all HCA hospitals, it reduced bloodstream infections by another 42%. So if you look at that, that's about 60% lower than expected. Oh yeah, one other thing, that was 2013. 2014, we did the health economics on this. Turns out for every 1,000 patients who are decolonized, you save $170,000. And oh, by the way, the enterprise value for our organization was just shy of $20 million. More importantly, the value to each and every patient who didn't get a potentially life-threatening bloodstream infection or MRSA is infinite. What about these learning opportunities? Are they rare? Are they subtle? Are they esoteric? Well, I'd say not. I mentioned that we're talking about the case of the billion-dollar babies next. Did you know, against the backdrop of all of evolution, against millennia, that in the last 35 years, we reduced the amount of time that women carry babies by nearly 10 days? And, if you think about evolution, babies are pretty tough. Have to be able to be born and survive when that saber-toothed tiger is threatening the colony or whatever. And so babies are really tough. So individual obstetricians, even a single hospital, wouldn't see the difference between 37, 38, or 39 weeks. So HCA got a question from the March of Dimes, which had become increasingly worried whether 37 and 38 and 39 equaled each other, and called the question and said, hey, you guys have a lot of hospitals and deliver a lot of babies. Could you collect some data? So 90 days, 27 hospitals, we looked at the outcomes for 17,794 babies. Turns out the risk for going to intensive care at 37 weeks was fourfold higher virtually than 39 weeks, virtually twice as high at 38 versus 39 weeks. Oops, not all the same. Now, please understand, I'm not talking about when mom or baby are in distress, really talking about an elective delivery. Gee, I'd like it on Tuesday. I don't have to, let's do it before the weekend, et cetera, et cetera. Turns out not to be a good idea. So lots of reasons for that. Immature lungs, obviously it disrupts the birth experience. It may impact lifelong learning, skills in math and reading, et cetera. Obviously uses unnecessary resources. So there's got to be a better way. Second trial on top of that was to really compare a bunch of different approaches to changing behavior, but the one that worked, without going into too much detail, was hard stop, where you get in trouble with your hospital physician leadership board if you do this. And that changed practice. Why was this possible? Again, because of interoperable health information. Well, what's the take home here? The learning opportunities are ubiquitous, but you got to intend to learn, they just don't happen. There will be a day when these data are fed to machine learning and statistical learning algorithms, and that produces things that you should worry about, but until then, work on hypotheses. These big data are useful for detecting rare events or uncommon manifestations of very frequent events, like delivery. And they're also a wonderful platform to change behavior and make care better. Changing behavior turned out to be the toughest part, and the social engineering in terms of working with expecting moms was very important, and of course every mom would respond to this: which baby would you rather take home, big brain or little brain? So this has become really a national standard, and the excess cost beyond the human cost was over $1 billion a year using most conservative assumptions. All right, so let me head down the home stretch. What tantalizes me? What terrifies me? What if that study didn't take 18 months? What if the data were already latent in the big data where there just was random variations? Screen isolate, decolonize, decolonize, 37, 38, 39. What if? Didn't take reduce 18 months, but 18 minutes. What if it didn't take the early elective delivery 90 days, but 9 minutes to ask these questions? What other things could we answer that are informative to cost, quality, personalized, and precision medicine, et cetera, if we could tap that collective memory? And how do you harvest that data dividend? Well, I travel a lot. This is in Reagan National Airport in DC. Can your doctor or nurse know everything known to medicine? Where our thought is this, is that, look, we're taking care of patients, and there is this flow from the patient through care that creates data. Imagine capturing that in a data system, spilling it back as knowledge, transforming it into applicable knowledge that can render better care, a virtuous cycle. Well, this is really our thought. And I mentioned a moment ago that one of my goals as chair of the Health IT Standards Committee was not only the interoperability of information for existing systems to talk, but really to build front ends that were user-friendly to tap into that information or to feed large analytic, innovative platforms for learning and improvement. And indeed, that's what we're focused on in HCA. We have a large system, about 5% of major hospital services, about 25 million annual encounters in our system, and we believe in collaboration broadly. And our chief data scientist, Edmund Jackson, showed us the relative magnitude of the data that are created. If Library of Congress is 10 terabytes and Google's about 15 exabytes, 10 to the 18th, we're there at about Jupiter with 120 petabytes. And that's a pretty good chunk of information. To be able to take back and feed in a user-friendly, we think of it sort of like an Amazon-like front end, to help support decisions in the long haul, but also in real time. And that's pretty exciting stuff. It gets at an opportunity to improve one of the locuses of high-cost care. Remember, care that's not perfect is by definition inefficient. Inefficient is expensive. So good quality, good safety is the best efficiency. And good business. So this is what I believe is the opportunity. This is what I believe is the data dividend. Yes, it's the opportunity to have interoperable information so patients can be cared for in an informed manner across time, over geography, and among care teams. But it's really the basis for a learning health system, a reinforcing cycle, a virtuous cycle that really channels that investment into better health and better care for the community. So, in closing, since you've invested, what's your ROI? It's this, is that all of us who are here by virtue of the investment that we've made in your organizations can tap standardized information that can improve value. It can improve quality in the numerator of the value equation. It can reduce cost. Or, like the reduced MRSA, it can do both simultaneously. What does this mean for the health workers as well? Well, it means that it's really energizing and meaningful work. Why? Because it improves safety, it improves effectiveness, it improves efficiency, it improves value, and it allows us to meet the patient's needs better than ever by respecting what's unique about them through the advanced analytics, through the big data. And address them with compassion and greater professionalism. And with that, what I think is so exciting is that we can take health care further. Thank you very much.